Hello, my name is Darryl Sneag. It is my pleasure to talk to you today about MR neurography occipital neuralgia. I am currently a musculoskeletal radiologist at the Hospital for Special Surgery in New York City. These are my disclosures. There are particular challenges of MR neurography in the head and neck region. First, it requires high spatial resolution, as most nerves in this region are small in caliber. Secondly, 3D techniques, which facilitate thinner slices and multiplanar reformations, or MPRs, as shown on the right, are critical due to the curvilinear course of nerves in this region. 3D techniques are often more challenging to obtain compared to 2D techniques due to time and ability to obtain the adequate sharpness. Commercially available coils are not specifically designed to image this region. Close contouring and high signal-to-noise ratio is required. Motion artifact, particularly swallowing and breathing in the head and neck region, can obscure important and relevant anatomy. Lastly, vessels can confound visualization of small nerves. At the end, when we create an image, even if we have appropriate imaging, how best can we as radiologists convey findings to referring physicians? So I'll try to touch on some of these points throughout my talk. I'd like to compare and contrast one standard commercial coil versus a prototype coil that I've helped develop here at the Hospital for Special Surgery. So on the left here is a schematic of a conventional 21-channel head and neck unit versus on the right a 23-channel coil we call the face. And here are images comparing the neck region using the same parameters. We can see a much higher signal-to-noise ratio on the right with the prototype coil. On the left here is an SNR map, or a signal-to-noise ratio map, showing the relative homogeneous signal-to-noise. But on the right here, we see much higher SNR on this heat map. And this affords us the ability to image either faster or at higher spatial resolution. So here is a maximal intensity projection on the left, where it's hard to delineate some distal segments of the occipital nerves compared to on the right with the prototype coil, where we nicely see these greater occipital nerves. Another technique that we use routinely in practice is a deep learning reconstruction algorithm. These are available commercially by all vendors. And these algorithms have been shown to improve the conspicuity of the epineurium and the fascicular architecture of peripheral nerves on two-dimensional MRN. Also been shown to enhance signal-to-noise ratio and edge sharpness on 3D imaging, and increase the relative signal and provide superior visualization for distal smaller nerve branches when using a particular 3D technique called DES, which also provides vascular suppression. So here's an example of a 2D image showing visualization of the greater occipital nerves as much sharper on the deep learning image on the right. We can use vascular suppression techniques, as I mentioned, a DES sequence for evaluating extra cranial segments of the cranial nerves. So here the inferior alveolar nerve on the left, the facial nerve, the spinal accessory nerve, and the vagus nerve, just to show some examples. We use a combination of both two-dimensional and three-dimensional techniques for imaging these nerves. With two-dimensional techniques, we can acquire a higher in-plane resolution, that is the resolution on a single slice, whereas 3D imaging, we can acquire higher through-plane resolution, much thinner slices, here to delineate a large hyper-intense facial nerve in a 35-year-old woman with Bell's palsy. Lastly, we can fuse both nerve and bone imaging to help guide surgery. Here's an example of a beaded configuration of the spinal accessory nerve in this patient with Parsonage-Turner syndrome. Here we can fuse the nerve image with a rendering from a CT-like MR image using a sequence called ZTE. And this can provide a roadmap for the surgeon for identifying, again, the beaded appearance of the spinal accessory nerve that he can go ahead and perform a neurolysis on. Let's now focus our attention to occipital neuralgia. MR neurography may play a role in the evaluation of this condition. In a study by Huang in 2017, they showed that the greater occipital nerve on average had a larger diameter compared to the on the symptomatic side compared to the asymptomatic side. It also had a higher signal intensity in contrast to noise ratio. However, in my experience, the small caliber of occipital nerves makes it difficult to reliably measure the size and signal intensity and compare to the contralateral unaffected side. Therefore, the current role of MR neurography is to identify altered morphology and particularly neuroma formation. Let's review the anatomy of the occipital nerves on magnetic resonance neurography, starting with the greater occipital nerve. We're beginning at the CT dorsal ganglion, following the nerve through the planes of the obliquus capitis inferior, then through the semispinalis capitis, and then lastly through the trapezius fascia. Here, the lesser occipital nerve, as it courses around the levator scapulae, sternocleidomastoid muscle, and then ascends towards the occiput. And lastly, the third occipital nerve, here running into the C3 dorsal root ganglion by the semispinalis capitis and the other paraspinal muscles here for reference. Let's next review some case examples. This is a 39-year-old woman with persistent occipital region pain following a left greater occipital nerve decompression for prior migraines. Here we see abrupt termination of the greater occipital nerve in a large segment of the nerve, and the green arrows point to a focus of susceptibility likely related to some very ferrous material left at the time of surgery. It could be even tiny shavings that can create that blooming effect. Here, not only suspected neuroma of the greater occipital nerve, but also of the third occipital nerve as well. And we suspect this because there's much larger size of the nerve compared to its expected size, but also termination of the nerve in a bulbous end. Here we can fuse the nerve and bone together, and I'll show you more examples in a moment. Next is a 70-year-old man with chronic headache, aggravated following decompression and neurectomy. Here we see, again, a termination of that greater occipital nerve and a neuroma. We can create a curved multiplanar reformation, again showing that termination. This again was a terminal neuroma of the right greater occipital nerve. This is a 70-year-old male following cervical spine surgery, now with occipital neuralgia. Here is a CT-like image using a sequence called ZTE. Here we see the artifact from instrumentation. Here's our DES sequence showing enlargement and termination of the left greater occipital nerve. We can fuse those together, and then we can create a cinematic rendering, which may be helpful to show both the provider the abnormality, but also the patient, particularly if surgery is considered. Let's show you an example next of lesser occipital nerve involvement without suspected neuroma. This is a 68-year-old woman with right occipital neuralgia for 2 years. Here we see focal enlargement and hyperintensity as the lesser occipital nerve courses along the posterior border of the sternocleidomastoid muscle compared to the contralateral normal left side. And here we can show the entirety of the course. So the lesser occipital nerve is in continuity, but it is enlarged and hyperintense. The last case I'll show you is related to arthrosis at the C1-2 lateral mass articulation. And this is just something to be aware of, that unilateral arthrosis at this articulation may contribute to occipital neuralgia by either causing primary degeneration at the joint and pain transmitted through the anterior ramus of the C2 nerve, or secondary impingement of the C2 nerve and ganglion complex by hypertrophic degenerative changes leading to occipital neuralgia. And so this is a 70-year-old woman with chronic headache and neck pain for years. Here we see hypertrophic degenerative bony spurring projecting into that right C1-2 foramen. On the bottom there, we see only very small osteophytes on the contralateral left side. Again, going now to the upper right, on our symptomatic side, we see this proliferation of kind of ill-defined mineralization obscuring evaluation of that DRG. And then here, showing you a nerve-specific sequence, we've seen posteromedial displacement of that right CT dorsal root ganglion by osteophytes. Therefore, in this case, cause of this patient's headaches was attributed to arthrosis. Again, that C12 lateral mass, articulation, and therefore she would be appropriate candidate potentially for a steroidal injection and a consultation with a cervical spine surgeon. Well, I thank you very much for your attention. I'd like to thank the MRI lab for the consistent support, and particularly my colleagues, Dr. Yenpo Lin, prior research fellow of mine, who helped study occipital neuralgia with me and continues to do so from Taiwan, and Dr. Exun Tan, an MRI physicist who I collaborate with on a daily basis. Again, it's really been my pleasure to speak with you today, and I hope you enjoy the conference.